I'm Tamar Pincus. I'm a professor of health psychology at Royal Holloway, University of London, and I've been researching pain for over 20 years. And I'm really interested in working with clinicians and with patients to help them understand and manage pain, especially when there is psychology making the management that much more difficult. What I mean by psychology here is the interaction of cognition, such as beliefs and expectations, with mood states, such as distress, anxiety, fear, and even anger and frustration, all mixing with the sensory information and combining to create the pain experience, and also influencing motivation and behavior. John is a 65-year-old man who has had back pain for several years. He consulted the GP 3 weeks ago, and they excluded red flags, meaning the GP didn't think that anything serious was going on. They did do some basic blood tests and they all came back normal. And the GP has assured John that he didn't need a scan. John still has pain and he's made a further appointment.
Morning, John. How are you doing today?
Oh, not so good, really.
In what way?
Well, it's this back pain, doctor. It's going on and on and on.
Okay, has it changed at all since we met 3 weeks ago?
No, it's just in my back all the time, all the time. I can't even, we went shopping the other day, came back. I couldn't even lift the bags of shopping out of the back of the car. My garden's like a wilderness. I want to get out there and mow the grass. I can't do that. Can't mow the lawn. I can't even go down to the bowls club and play bowls. So I'm really feeling a waste of space at the moment.
When I examined you, I felt it was the same pain that you'd had for a while, really, didn't I? I think we did some blood tests which were normal, which is really good, which suggests that there's probably nothing serious going on. So we should feel reassured about that.
I'm not reassured. It's just going on and what's going to happen? This is so frustrating. I'm trying to tell this doctor how this back pain of mine is getting to me, but I feel she's not listening. She keeps telling me there's nothing seriously wrong. But it's serious to me, all the things I can't do. I'm just so frustrated.
At this point, I'm wondering where this consultation's going. I felt I reassured John last time we met. I've tried to reassure him again today. I've gone through the normal blood tests and was quite positive about them. But he keeps repeating himself. He keeps telling me how bad the pain is. I feel I'm repeating myself, and I'm beginning to feel quite frustrated.
Here's a useful tip. When people keep repeating themselves, they probably don't know that you've heard them. And it also probably means that they're quite concerned about the point they keep repeating. There are several things you can do to ensure that the patients know that they are being heard. You could summarize what they've said. You could focus on any emotive words that they've used and ask them to explain a bit more. You could ask for clarification. You could repeat back the key sentences that you've heard. But what's really important, even if you feel that you're pressed for time, is to let them finish speaking without interrupting them. Another issue with openly discussing psychology with patients is that sometimes it's really tempting to duck. It's really tempting to avoid the whole psychological caboodle and pretend that the patient doesn't come in with psychology. But of course, pain is always psychological, even when it's physiological as well or social as well. And it's impossible to avoid that side, even if practitioners feel unskilled or that side is beyond their remit. Why is it so important not to duck psychology? Well, let me give you a really good example. This is an example from a student of mine who told me that she's afraid of spiders. She told me that as soon as she walks into a room, she starts scanning it to see if there's any spiders there. And she said if she doesn't find a spider, then that's the worst scenario, because it means that either the spider is ambushing her or that he's gone to get all his cousins and then they'll all come back. In other words, even when there isn't a spider there, the fear of spiders remains. And for her, it influences her in such a way that when she's trying to do something, if there's a stain on the carpet, or if she sees the word crawly or creepy anywhere, it pulls her attention away and stops her doing what she's trying to do. It's exactly the same with pain. That attention bias of pulling your attention away from what you're trying to do towards threat, we know that happens with pain as well. the interpretation bias of seeing something that might not be threatening but perceiving it as threatening. That happens with pain. So, for example, patients might have a signal which is ambiguous, might be something itchy, or feeling something that is not a new injury. But the brain, once it's primed to think of these signals as threatening, will produce a full-blown pain experience. And the more afraid you are, the more worried you are and concerned about pain, about movement, about the consequences of pain, the more likely you are to experience that full-blown pain experience. So fear can actually cause pain without further injury. What I mean here is that selective attention to body signals can result in hypervigilance. Patients will notice more pain and interrupt their current goals. They may also start to interpret neutral signals as threatening, resulting in increased worry and possibly avoidance of movements and activities. This in turn can lead to catastrophic thinking, which can be overwhelming and lead to seeking help and reassurance from practitioners, even if there's no new injury or change in pain.
At this point, I realise he's got some underlying concerns about the pain that up to now he's not been able to express, and I've not allowed him to explore. So hopefully we'll be able to change the course of the consultation by giving him some space to talk about his concerns.
Well, I'm not reassured. I mean, what's going to happen next?
It seems to me that you're quite worried about your pain.
I am. I'm scared.
Yeah, can you tell me what you're worried, what you're scared about?
Well, I'm scared that I've got something like cancer in my spine or something like that. You know, I'm terrified I'm going to end up in a wheelchair.
It sounds to me like we're dealing with fear, and perhaps the fear is as important as the pain itself, do you think?
Yeah, because I am scared.
How important is it to identify psychological factors early on when somebody presents with pain? Well, we carried out a systematic review and we find the same thing again and again. The predictors of those who move on to have persistent pain are usually psychological. And amongst them, the most robust are things like fear and depression. Fear, depression, and anger make pain worse and result in poorer outcomes and more disability.
Shall we try and tackle both then, both the fear and, the pain?
Now that she understands how important John's fear is, Carolyn can address his catastrophic thinking. My research suggests that education about pain and information about managing both the pain and the emotions surrounding it are useful to patients.
Do you know, this is the first time I've been able to tell anyone how scared I'm feeling. It's such a relief.
From now, I know how to support this patient and how to manage them.
We carried out a survey with a large number of people with chronic low back pain. We asked them whether they agreed with the explanations they were given by their doctors, but we also asked them whether they thought something else, something serious was going on with their back. Almost all of them agreed with the explanations, but the surprise was that many of them still felt there was something else undetected, not asked about, going on with their back. Clearly, there's much more work to be done to reassure patients.